Covid-19 is causing the worst pandemic of our lifetimes. We at Barts Health will do our best to save as many lives as possible.
But our best is bloody good, and we're going to do a fantastic job for Londoners over the next few weeks.
Adapting at exceptional pace.
It's put in, and there are markings down the side.
ICU ventilators have a double limb set.
We're going to talk about pumps.
We in the NHS cannot fix this alone.
But we need your help to do better.
Hi, my name's CARMEL and I'm Head of Radiography at Barts Heart Centre. St Bart's Voices is a podcast that we were and still are planning to release episodes for at a later date that will aim to tell the stories of those working at Barts. For now, we have released 2 special episodes. The one you're about to listen to is a COVID update and Q&A, which is led by JONATHAN LAMBOURNE. The episode was recorded the night before the PPE guidance change, so please be aware that although it's mentioned in the following recording that for negative/non-suspected cases that PPE would not be necessary, this has now changed. Surgical masks, aprons, gloves should be worn for all patients if you are likely to have close contact that's within 2 metres. Please familiarise yourself with the new changes and guidance. It's available via WeShare. Lastly, I'd just like to say a huge thank you to all involved. JONATHAN LAMBOURNE for leading the Q&A, our panel including FIZZAH Choudry, Holly Dorr, MARC HORTON and Michael SPILLANE, and to Rodnie who did a fantastic job of recording this episode. This is also available as a video cast, link via WeShare and in bio. Thanks for listening.
So I'm John Lambourne, I'm one of the Microbiology and Infectious Diseases Consultants at Barts Health NHS Trust. And I think I'm talking about PPE in the setting of the COVID pandemic. I guess the first thing to say from the Trust side is that we are looking to and following guidance from Public Health England, which, as is the case in all unexpected situations like this, changes with time. And so just thinking back in the last couple of weeks, how things have changed. So when the epidemic and then pandemic was first realised, that the national and international response is to assume the worst, I guess, in terms of transmission and infectivity and case fatality and so on. And so novel infections are normally classed when they emerge as what are called high consequence infectious diseases, so HCIDs. And the normal or appropriate infection control response is to try and introduce the highest level of protection as is possible in terms of assuming it's aerosol transmitted. So that's kind of long aprons, long gowns, gloves, so FFP3 masks and eye protection. But then as we get to know a bit more about the infection and how it's transmitted, then guidance generally kind of changes as we get to know a bit more about how, what's the major mode of transmission. The interesting thing that this pandemic has thrown up, I guess, is how under-researched the idea of respiratory transmission is. So there's a long-standing dogma that says it's either droplet transmission or it's aerosol transmission, and that's the received and accepted wisdom and dogma, but without, I gather, a huge amount of data. And the difference between those two things is that it's to do with particle size and how those particles respond in the air and to gravity. And so droplets are generally large particles, so greater than 10 microns in diameter. And they are believed to generally follow the laws of gravity. So they are expelled by kind of coughing or sneezing or sometimes even by just talking. But those droplets obey gravity, so they fall to the ground, which means they have a limited radius around the individual. And so the main infection risk for them is thought to be contaminated kind of surfaces around the individual. So it's bed rails, it's side tables, it's stuff that the patient is around, and some person-to-person transmission in terms of droplet for close contact. So say if you're less than a metre and a half away, the idea is that droplets can be expelled but then land kind of on you or possibly be inhaled into the mouth. And that's how infection is set up. So either by inhalation into the mouth, contact with the eyes, or the person kind of touching the environment and then rubbing their eye or picking their nose or sucking their finger or that sort of thing that we do all the time. It's interesting, I've started kind of looking around a bit more now, and you notice a group and you realise how often we kind of do our nose, we kind of scratch our ear, we kind of rub our eyes, all the things that we just do habitually and without thinking, and then you suddenly kind of go, oh, hang on, I do this. So that's the droplets, and the idea about the droplets as well is that even through inhalation, they're thought to be large enough that they don't tend to penetrate that far down into the airways. They don't go all the way down into the small airways at the periphery of the lung. And so it's thought that they tend to establish infection in the upper airways. So that's droplets, and which is why what we call kind of droplet protection PPE is geared towards protecting that sort of exposure. So it's a surgical mask, so it's to stop the droplets landing on you. It's an apron, again, to stop droplets landing on you, and it's gloves, so in terms of touching things. And it's eye protection when you're, again, in close contact with someone who's kind of coughing or sputtering or has a nebulizer going or something like that. The other group is thought to be the kind of aerosol transmission. And that is thought to be due to smaller particles, so less than 10 microns or sometimes even less than 5 microns. And the issue with those is that because of their size, is that they don't obey the laws of gravity, and so that they can remain in aerosols in the air for a period of time, and they can have a much wider range, and they follow currents and eddies. So there's an aerosol, someone opens a door, that will generate an airflow that the aerosol will allow the aerosol to kind of transmit out and about. And because they don't obey gravity, they can, with breathing, they can entrain under the surface of the mask, which is why for aerosol PPE, it's much wider coverage. So again, it's gloves, but it's a long-sleeved gown. It's what's called an FFP3 mask, and again, it's eye protection or a visor, again, to try and prevent both droplet and aerosol. The reason for the FFP3 mask is that it's tighter fitting and has a much greater kind of filtration capacity than a surgical mask. Now, there are some studies that show that there's an incremental increase in protection from wearing no PPE to wearing a surgical mask to wearing an FFP3 mask. So it's not that a surgical mask confers no protection, it confers protection against droplets, and actually for aerosols will do quite a bit of good as well, but in order to be fully protected, the idea is that you need an FFP3 mask. But actually that there's some more recent research that suggests that dichotomy between droplet and aerosol is actually possibly a false dichotomy, in terms of actually there's probably a grade, and so there are a relatively short list of conditions that we term aerosol generating, and the data behind those is generally around, it's very often not mechanistic studies in terms of trying to generate an aerosol and see if it flows. Often it's case reports of saying this procedure was done, someone who was in the room during that procedure got the infection, therefore there must have been an aerosol rather than a droplet. And so that's the level of data I think that we're at in terms of what determines an aerosol generating procedure. So it's things like kind of intubation, extubation, high flow oxygen, non-invasive ventilation. Where the idea for aerosols is you need quite high flow air going over a surface. But there's debate about, is coughing an aerosol generating procedure, is nebulized therapy an aerosol generating procedure, is doing CPR an aerosol generating procedure, is doing an OGD, so a camera down the gullet sort of test, an aerosol generating procedure. Those are all things that at the moment I thought not to be, but largely because there haven't been the cases described following those procedures. That doesn't mean necessarily that they can't be associated with aerosol. So I think one benefit, if you can think of it in that way, that this pandemic will have is that there'll be an awful lot more focus and research in terms of aerosols, and so our awareness and knowledge and practice of proper personal protective equipment will improve from now kind of going forward. But I guess one of the struggles is that it feels like guidance is changing every week. And there's nothing like changing guidance to make people feel nervous, unprotected. The people who are telling them don't know what the hell they're talking about. That's very anxiety. So we started off this kind of saying, if it's a suspect COVID case, you can wear droplet PPE. As soon as that patient becomes a COVID PPE, irrespective of what you're doing, you suddenly change your PPE to aerosol. And then we said, no, don't do that. Just wear droplet PPE for proven and suspect cases unless you're doing aerosol-generated procedures. And here's a list of aerosol-generated procedures. And then this week we went, actually there's one list. The list of aerosol-generated procedures now is a bit longer. So there's a constant iteration that is necessary because of our ignorance, but doesn't help people who work on the front line kind of going, well, what I was doing last week is the same thing as I'm doing this week, but I'm being told to do something different in terms of my PPE. So it's trying to manage that that risk, I guess, which is a challenge. I mean, I think there's a whole bunch of things that we could talk about in terms of PPE, but it's just interesting to think about the evidence behind it and the lack of evidence behind it and how things are evolving as we go. I mean, I definitely, the data from SARS is that some PPE is better than no PPE, and I think there's another important thing to state is that putting PPE on is an important part, but actually taking PPE off can be a risk as well. And we learned from Ebola and also from other outbreaks that actually the risky time and the point of you're most likely to inoculate yourself is as you're taking the PPE off. Putting it on is fine, that's easy, you're clean, you're putting PPE on, whereas you're taking it off, you've got a contaminated surface on the outside. The steps required to take it off and take it off properly so you don't then kind of get a handful of stuff and rub your eye with it, that's where it's important. And I think we pay a lot of attention to the donning, but less attention to the doffing or taking off of stuff. So it's just being aware of those sorts of things. Just in terms of how guidance may change, conceivably the current PhD guidance states that if you are going to do clinical work in close contact with a patient, so a metre and a half or less, and the patient is proven or suspect COVID, and they're not having any aerosol generating procedures, then that member of staff should wear droplet protection PPE, which is surgical mask, apron, gloves, plus or minus eye protection. What we conceive as proven COVID is easy, that's a swab that tells you they're positive, but a suspect COVID case is a slightly more difficult thing to define. And so the initial guidance was quite tight. It was, do they have a new cough and a new fever of over 37.8? In some individuals it was expanded to, do you have any of these symptoms? So runny nose, sore throat, myalgia, flu-like illness and a fever. Now as the pandemic rolls on, we realise that there are perhaps a greater proportion of individuals who are either asymptomatic, who we're detecting virus on, or who are what we call kind of pre-symptomatic. So we detect the virus, they have no symptoms, but 2 days later they get their cough and things. So our understanding, so what we used to think was from 2 studies of individuals who were repatriated from Wuhan, one group into Germany, one group into Singapore, who were quarantined and followed for kind of a period of 14 days and were swabbed throughout their stay. About 2% of those individuals became positive on swabbing but had no symptoms. So we thought that the asymptomatic carriage rate was actually really quite unusual. We thought it was about 2%, and we thought that the onset of symptoms coincided pretty well with the onset of being infectious. But actually more data is suggesting that perhaps a greater proportion either don't have symptoms at all or are asymptomatic while shedding virus and then go on to develop symptoms. So I think the guidance is changing in light of that. So it may be that actually we end up viewing any patient or perhaps any member of staff as an extension of that as being COVID positive, and so we invoke appropriate PPE for that. And what is that? It's still, if you're not touching someone, you don't need to worry about kind of gloves and apron and things. It's still about kind of wearing masks. So we may move towards a more Southeast Asian model of PPE, which is widespread mask use in a clinical setting, but also kind of, I guess, outside of the clinical setting as well. So that I wonder is maybe how we'll go.
Thank you. That was really helpful to do a little bit of preamble about PPE. I think something that's causing everyone a bit of concern and worry is exactly as you said, the changes that happen so frequently, and also the concern about the low risk and the suspected and how you define those, as you've just said, and whether we should be wearing PPE for all patients that we see. And if we're wearing them for all patients in one area, then should the whole hospital work in exactly the same way and everyone be wearing PPE or a certain level of PPE at least for all individuals. And I think one of the concerns is that people are worried that is it is that decision that hasn't yet happened, is that based on availability and resource, really?
Yeah, no, definitely. So I think that there is resources definitely an issue. I'm not sure about supply. I have to be honest in terms of those are decisions and planning that's made at a level kind of above. So I don't know. My understanding is that there is. That's one of the reasons, I guess, for trying to make sure that the appropriate PPE is worn in the appropriate scenario, I guess. So clearly, long sleeve gowns and FFP3 masks are more difficult to make than aprons and surgical masks, and are in shorter supply. And so I think the distinction between wearing droplet protection PPE and aerosol generating procedure PPE still holds, and I think that's important. I think we should protect or reserve the aerosol protection PPE for those procedures where it's most needed. What's disheartening to see is colleagues walking around wearing FFP3 masks in non-clinical environments, because those are masks that are really needed in situations where there are aerosols being generated, and that is not. Well, there's lots of debate about what procedure, aerosol generating procedures. It's exceptionally unlikely that sitting in your office doing your paperwork or in the canteen exposes you to a significant amount of aerosols and things. But there is definitely a resource implications in terms of that, which is why I think that should be protected. In terms of the droplet precaution PPE and protecting yourself against things, again, it comes down to where are you going to get the infection from, and it's going to be close contact, meaning kind of within a metre and a half of patients and potentially of others, which is why wearing PPE is only part of or wearing a mask is only part of the whole package. So in the ward setting, it's wearing a mask, but also wearing gloves and aprons if you're delivering kind of patient care. So you can protect your mouth, but if you're not wearing your gloves or not wearing your apron, then you're doing less than half of the job. And likewise, in terms of contact with colleagues, it's felt to be kind of close contact, and the duration of contact clearly has something to do with it. If you're passing a colleague or someone in the corridor, then your risk of acquisition is much lower than if you're sat in the canteen or you're sat in a radiography reporting booth or that sort of stuff when you're quite close together. So I think in those situations it's about doing an individual risk assessment to going to go, look, how close am I to my colleagues for how long a period of time, and actually if it's close contact, so metre and a half for 15 minutes or more, which is what PHE defines as close contact, then if we expand the suspect to everybody, then in that situation it wouldn't logically be unreasonable to wear a surgical mask in that setting. The question then comes in terms of if you're doing, say, a ward round of 10 patients, does that mean you've got to wear 10 masks the whole time? Actually, I don't think it does, because once the mask is on, and if it stays on, then you're protected. If bugs land on it, they're not going to leap off from patient 1 and affect patient 2. They're there. The key is once it's on, it stays on, and it's not touched or fiddled with, because the risk then is patient 1 coughs on you, bug lands on your mask, you're protected because you've got the mask on, but you then scratch your nose under your mask, your finger then has the bug on it, you then go to patient 2 and you pass it on. But so long as the mask is kept on and not fiddled with, then it's fine, and it can be worn for as long as is comfortable. So the general guidance is it can be on for kind of 3 or 4 hours. Normally after that time they get a bit kind of moist or a bit uncomfortable or a bit sweaty, and it just needs to kind of come off. But it's not mask on, mask off, mask on, mask off. That's in the clinical setting. Outside the clinical setting, again, do you need to put a mask on when you're going to the canteen, a mask on when you're leaving the canteen? That's a level of detail that I don't think we've got worked out. But you could argue that actually you can have a mask, pop it down, pop it back on again, then hand hygiene, and then the issue is not forgetting the hand hygiene bit in terms of touching the mask that may be infected, and that sort of thing. And then again, in terms of aprons and gloves and eye protection, again, it's as if you're in close contact and likely to be exposed to kind of droplets and things. So again, I don't think sitting in the canteen you need to be wearing an apron and gloves, but again, it's about hand hygiene. So you've just finished in the canteen, you put everything away, you're about to go back to your clinical setting, wash your hands. You're about to go see a patient, wash your hands. There's debate about eye protection. Again, mucous membranes on your eyes, they're a portal of entry, and so I would, I guess, support more widespread wearing of eye protection, and that can be the big face visors, but equally it can be goggles, or it can be the wraparound kind of clear glasses that people wear in the CathLabs, or they wear in theatres, or that sort of thing. They can be reused, so if some of them can be reused. The debate is exactly how you reuse them. There is a guideline in terms of how to reuse the visors up on ITU. There's a bucket of chlorine essentially that they sit in for 15 minutes, and then they have to dry. They then get taken around to the clean area. They get reworn. If people have got their own eye protection, then I would wager that giving them a good wipe with either a green or a red Clinell wipe, which have the adequate disinfecting sort of properties, would be fine. So if you've got your own wraparound things, it's a bit about kind of common sense. There's no way, we can't be sterile, we can't live in a bubble. It's about minimising, but there's no capacity to completely eliminate risk of exposure. It's simple things. It's just remembering kind of hand hygiene and appropriate protection, I think. So, and then in terms of the supply of stuff, it's a good question. So we're getting lots of queries about people emailing in saying, look, I can order, I've been offered a whole bunch of masks, a whole bunch of gloves and things. So there is a system for assessing that. We're asking that people will contact kind of Karen Bates, who's the lead for kind of procurement and operations, to vet the referrals and also infection control, because surgical masks ideally need to pass or have been manufactured under certain standards and have certain performance characteristics. Because what we don't want to do is have a whole bunch of surgical masks that are not fit for purpose and actually put staff at more risk or give them false reassurance. So there is a process in place that says if you do hear people saying, oh, I've got a mate in China who wants to send us 4,000 masks, great, let's put it through Karen Bates and infection control.
And what are your thoughts on patients wearing masks?
Yeah, no, so I think I would say that's a good idea when, in certain situations, there's little point a patient in a cohort bay or in a side room wearing a mask for the whole time, because actually they're in the room, people coming into them are going to be protected. The situations where I think it is useful is in ideas of transit. So say, for example, you've got a patient on the ward who needs a CT, then in terms of moving that patient down, just to try and minimise the risk en route to potential kind of passers-by or equipment or that sort of stuff. If the patient just wears a simple surgical mask, that's good. What we said in terms of patients going into theatre, for example, they're being retrieved from the ward, taken into theatre, we're asking that the team who pick them up pop a surgical mask on the patient, bring them into the anaesthetic room and proceed. So I think that's fine. I think that expecting patients to wear masks while in their rooms or cohort bays for prolonged periods is not necessary, is largely pointless, and will probably be quite uncomfortable, I think.
I just wanted to ask, in terms of testing, with the risk of the false negative rate with the home testing, will we be taking into account patients who have had previous tests at home? Will we take this into account with our care at Barts, or? Yeah, so testing is another big frequently asked question, and I guess there's two things. There's two different tests. One is the tests that are currently underway to detect viral genetic material, so viral RNA, and that's what we have at the moment in routine practice in the lab at the Royal London. There are, I gather, a number of tests that have been put out for kind of home testing and bits and pieces. I guess I'm slightly reluctant in terms of if a test is going to be used, it needs to have a certain set of performance characteristics and it needs to have been evaluated in an appropriate setting. So the tests that we use have all been validated by Public Health England. What I don't know is whether all the tests on the market have been evaluated or whether there's a list of approved tests or non-evaluated tests. I would encourage people to stick to tests that have been properly evaluated. So what they'll do is they will have a sample that's got known positive, known negative, and they will run those samples through the different tests and kind of come out with performance to say, right, what's the low limit of detection? What's the false positive rate? So it picks it up, but actually it's not truly there. False negative rate where the RNA is in the sample, but the test just doesn't pick it up. So I think for every test there needs to be an understanding of its performance characteristics. And there's clearly a lot of commercial interest in terms of developing tests for COVID. And so with that, there needs to be a certain amount of caution in terms of which tests get the thumbs up or don't in terms of CE marking or approval by PHE or European regulation and so on. So we know that the test that we use has gone through that process, and we know it's valid. I mean, no test in the history of microbiology or virology is ever or will ever be 100% sensitive and specific, meaning it will always identify an infection if it's there, and it will kind of only identify that infection. So there's always going to be a rate of false positive, meaning that you get a positive result, but actually the patient doesn't have it, or more importantly, in this case, false negative, where the test comes back as negative, but the patient actually does have it. So some of that comes down to sampling, and where you sample. And so we think that throat swabs probably have the lowest sensitivity. Nose swabs have a higher sensitivity. So we think throat swabs probably about maybe 40 to 50% sensitive by themselves. Nose swabs probably about kind of 65, 70% sensitive. The two combined is probably about the same, so 75% kind of sensitive. But that means there's still 25% of people who, if you really look or look at a different place or you look again, will have COVID detected, but just don't on that sample, which is why we say one swab in the throat and in the nose. Throat swab, you've got to gag, because it's got to be a proper deep throat swab. And the nose, it's not just a tickle in the front of your nose, it's the swab going right to the back of your nose where you feel resistance and you twizzle it around so you feel like you're about to cry. It's not hugely pleasant, but it means you've got the best chance of finding it if it's there. What we're also doing now in terms of patients who are coming through on the Barts site alone, who are having thoracic surgery and cardiac surgery, where we've got access to deep respiratory samples because the patient's intubated, is getting some of those deep respiratory samples, because we think that the sensitivity of a deep respiratory sample is probably more up in the 95, 97% thing. So if we say that someone's had a deep respiratory sample sent and that's negative, actually we're much more confident to say, do you know what, this patient doesn't at this stage have COVID, I think. So I think you're right. The other thing about testing that's going to be really important coming up is the idea of serology. So PCR tests currently will detect viral genetic material. Serology is a blood test which asks, has your immune system seen this infection? So we do serology for kind of Hep B, for measles and mumps and all that sort of stuff to check immunity. And so this is asking, is this person immune now to COVID? There are several challenges to that, in that there are 4 or 5 other strains of coronavirus that circulate most winters anyway, that we're all exposed to and that we will all have antibodies to. We will have all developed some immunity to them. What we don't want to do is we don't want to pick those antibodies up because everyone will have them. We want to pick antibodies that are specific to COVID. And also, the body's immune system will evolve its immune response to COVID. So you'll get antibodies. Imagine this is your COVID bug. You'll get antibodies directed to lots of different bits of the bug. So the outer bit, the inner bit, the RNA, the protein, all the different bits to it. What we would really like to measure are antibodies that have a functional impact, meaning that if you're exposed to COVID again, those antibodies bind to the bug and prevent it binding to host tissue and prevent it invading and things. So you can have antibodies that might exist that don't do any of that, and you're re-exposed and the bug kind of gets in quite happily. There's no point measuring those antibodies. We want to measure what are called functional antibodies that neutralize the virus and prevent it entering. And so there's a couple of limitations, or not limitations, there's a couple of bits that serology has to get right for the test to be meaningful. And again, the same thing holds in terms of lots of people will produce serology tests to say, this will tell you if you've got COVID or not. But I think that, again, we need to have some caution and put through the right validation for these tests to go, what's the false negative, what's the false positive. What you don't want to do is to say that we've detected COVID antibodies, great, you're protected, but actually that person isn't. They then perhaps don't observe PPE quite as cautious as they should do, and then they get it. That will be a risk and a poor outcome. So there's a bit of caution before we widespread kind of release those sorts of tests. And then coming back to the serology, that begs the question, if I have antibodies, does that mean that I am protected? Does that mean that I can't get it again? And I think the current understanding is
Probably yes, for a couple of reasons. So one, if we look at MERS and we look at SARS, individuals who have had those, they're both very similar, they're quite similar coronaviruses to COVID. Individuals who have had those infections generally demonstrate reasonably high concentrations of antibodies to those infections for a year, 18 months after they've had the infection. So people do generally make antibodies. And as far as I'm aware, there have been no documented cases of reinfection with either MERS or SARS. The caveat to that is that compared to this, they were both tiny outbreaks. And so not many people were exposed. From what I gather, I don't think there are that many cases or reports of individuals having COVID twice. There have been a couple of case reports where people say they had it twice, but I wonder whether that might be more to do with the inaccuracy of swabbing. So you get a patient who was tested positive, swabbed on day 3 negative, tested on day 7 positive. That I don't think is a reinfection. That I think is one infection where that middle test was null and void, I think. So, but the expectation is that if you have the capacity to make antibodies and you can detect them, then you should be protected. Now that doesn't mean we're going to send people to the front line who have had it and have antibodies with no PPE, but it just means that you go into that situation wearing PPE, perhaps a bit more reassured. What it will really help with is the flow of patients in through surgery. At the moment, we're trying to figure out who's COVID negative, who's COVID positive. We're evolving a situation where we end up treating everyone as if they've got COVID. But actually, down the line, in 2 months' time, we may be in a situation of going, right, what's your COVID blood test? Your serology is positive, fine, you've had COVID. You can proceed down a clean patient pathway and no one has to worry about it. We haven't got to worry about, are you going to ping up positive in 2 days' time or that sort of thing. So I think again, like things will evolve in serology. I think we'll have to see how that impacts. I think it will impact. It'll be interesting to see.
There's been a lot of talk from government people about and in the press about the antibody testing for NHS staff, which seems like it will be, you know, a massive thing when that's available. How long do you think it will realistically be before a usable test is available?
Definitely. I think it's a good question. I think there are definitely tests and kits that have been manufactured and that are going through the evaluation process currently, with a variety of formats. So some of them are like kind of pregnancy test, even like a fingerprint of blood onto a stick and it tells you yes or no. Some of them are more conventional serology tests that go onto an analyzer. I guess the important thing to say, I guess, with that is that doing the DNA test, or the RNA test, sorry, the molecular test, there are quite a few more steps involved. It's quite more labour intensive. It requires more validation, and scaling up a PCR test is quite difficult, whereas scaling up a serology test, I think, is much easier. And the analyzers that are already in place for processing thousands of HIV tests, Hep B tests, pregnancy rubella serology, syphilis serology exist. And if they can get onto that platform, then I think that the idea of reagents and of kit space and of machine space will be less of an issue. I think it may still be an issue, but perhaps less of an issue. But in terms of time from kit manufacture to widespread release, I mean, everyone's working hard on it, but I would put a figure of a couple of months on it still, just because we need hundreds of samples to validate, to go through. I mean, the nice thing is that all virology labs will have freezers full of serum of people who have not had COVID. So if you go back a year or 2 years, no one will have had this infection. And so you've got millions of samples that are negative. So you've already got a bank of samples, and now we're getting lots and lots of positives. And so the raw materials required to validate the test, I don't think is going to be difficult, but it just needs to be done. I think I'm putting 2 months. I'm hopeful it might be sooner, but let's.
Realistic.
Yeah, I think so, and I think things change. I think, and then once the test becomes available, scaling it up, and then how it affects our management, I think will take a week or two to really kind of bed in. I think so. Yeah.